ECG Training Module 4 by Brad Chapman RCT. Objectives: Arrhythmia recognition, sinus, atrial, blocks, ventricular. Arrhythmia recognition. Rhythms coming from the synode. Normal sinus rhythm. This rhythm originates from the synode. This specialized piece of tissue generates its own impulse at a rate of 60 to 100 bpm. Sympathetic stimulation can accelerate the synode up to a rate of 150 bpm. Woods, 2000. P waves and QRS are usually normal and have a 1-to-1 ratio. Rate, 60 to 100 bpm, beats per minute, regular. Arrhythmia recognition. Sinus bradycardia. Rhythm, regular rate, less than 60 beats per minute. QRS duration, normal. P wave, visible before each QRS complex. PR interval, normal. Usually benign and often caused by patients on beta blockers. Arrhythmia recognition. Sinus tachycardia. Rhythm, regular rate, more than 100 beats per minute. QRS duration, normal. P wave, visible before each QRS complex. PR interval, normal. The impulse generating the heartbeats are normal, but they are occurring at a faster pace than normal. Seen during exercise. Arrhythmia recognition. Sinus arrhythmia. The ECG is of normal pattern but the rhythm varies corresponding to respiratory cycle. This is commonly found in young people. P waves and QRS are usually normal and have a 1-to-1 ratio. Arrhythmia recognition. Sinus arrest. The SA node fails to initiate impulses. No P waves, no QRS. Arrhythmia recognition. Atrial rhythms. These rhythms come from a different focus or site than the SA node, normal pacemaker of the heart. Usually somewhere within the wall of one of the atria. The P wave is often of different shape. The QRS is usually initiated in a normal manner. Arrhythmia recognition. Atrial flutter. The waves are very rapid, 300 bpm, usually sawtooth in pattern. The AV node cannot transmit every impulse to the ventricle. The ventricle will respond to every second, third, fourth etc. flutter wave. Rhythm, regular rate, around 110 beats per minute. QRS duration, usually normal. P wave, replaced with multiple F, flutter, waves, usually at a ratio of 2-to-1, 2F, 1 QRS, but sometimes 3-to-1. P wave rate, 300 beats per minute. PR interval, not measurable as with SVT. The abnormal tissue generating the rapid heart rate is also in the atria, however, the atrioventricular node is not involved in this case. Arrhythmia recognition. Atrial fibrillation. There are no consistent P waves. Because the irritable focus is so rapid, more than 350 bpm. You see wavy series of fib waves. The ventricular response is totally irregular. Rhythm, irregularly irregular. Rate, usually 100 to 160 beats per minute but slower if on medication. QRS duration, usually normal. P wave, not distinguishable as the atria are firing off all over. PR interval, not measurable. The atria fire electrical impulses in an irregular fashion causing irregular heart rhythm. Arrhythmia recognition. Avenue node rhythms. When the pacemaker of the heart shifts down to the A-V node, the P waves are altered. This causes the P waves to be inverted. Because the focus is so close to the ventricle, the atria and ventricle contract at about the same time. The P wave occurs just before, after or buried in the QRS complex. Nodal rhythm. The rhythm is regular but the P wave occurs just before the QRS, after or is buried in the QRS. Your P wave can also be inverted. Nodal tachycardia. The rate is usually between 100 and 150 bpm. Since conduction beyond the AV node is normal, we usually get a QRS complex which is normal. Inverted P waves are seen. Arrhythmia recognition. First degree avenue block. Prolonged avenue conduction time. If the pacemaker is normal and in the SA node, the P wave will be normal in shape. But because of defective, slow, conduction in the AV node, the PR interval exceeds the upper limit or normal. The heart rate and rhythm are unaffected. Your PR interval is greater than 20 seconds, 200. Rhythm, regular. Rate, normal. QRS duration, normal. P wave, ratio 1:1. P wave rate, normal. PR interval, prolonged, greater than 5 small squares. Arrhythmia recognition. Second degree block type 1, Wenke block. Here, there is a progressive lengthening of the PR interval to the point where an impulse does not reach the ventricle and a beat is dropped. Rhythm, regularly irregular. Rate, normal or slow. QRS duration, normal. P wave, ratio 1:1 for 2,3 or 4 cycles then 1:0. P wave rate, normal but faster than QRS rate. PR interval, progressive lengthening of PR interval until a QRS complex is dropped. Arrhythmia recognition. Second degree block, Mobitz type 2. This is characterized by an occasional or cyclic block of conduction of an impulse without previous lengthening of conduction time. Rhythm, regular. Rate, normal or slow. QRS duration, prolonged P wave, ratio 2:1, 3:1. P wave rate, normal but faster than QRS rate. PR interval, normal or prolonged but constant. Arrhythmia recognition. Third degree avenue block. Usually called a complete heart block. There is a delay before the idioventricular pacemaker goes in action. During this time there is no ventricular contraction, no QRS, and oftentimes the patient may faint. There is no impulse from the atria that is reaching the ventricle. Rhythm, regular. Rate, slow, ventricular rate 20 to 40 BPM. QRS duration, prolonged. P wave, unrelated P wave. Rate, normal but faster than QRS rate. PR interval, variation. Complete avenue block. No atrial impulses pass through the atrioventricular node and the ventricles generate their own rhythm. Arrhythmia recognition. Right and left bundle branch blocks. When the conduction through the right and left bundles are impaired, the impulse must travel through non-specialized tissue. This prolongs depolarization, producing a longer QRS complex. Arrhythmia recognition. The criteria for a LBBB. Wide QRS complex greater than 12 seconds. Upright, possibly notched QRS complex, RSR, in lead I, V5 and V6. Predominantly negative QRS in V1. Rhythm, regular. Rate, normal. QRS duration, prolonged. P wave, ratio 1:1. P wave rate, normal and same as QRS rate. PR interval, normal. Arrhythmia recognition. The criteria for a RBBB. Wide QRS of at least 11 seconds. An RSR in V1 and V2. Wide S wave in leads I and V6. Arrhythmia recognition. Ventricular rhythms. These impulses are coming from the wall of the ventricles. Ventricular tachycardia. This is a dangerous rhythm which requires immediate attention and prompt correction. Rhythm, regular. Rate, 180 to 190 beats per minute. QRS duration, prolonged. P wave, not seen, results from abnormal tissues in the ventricles generating a rapid and irregular heart rhythm. Poor cardiac output is usually associated with this rhythm, thus causing the PT to go into cardiac arrest. Shock this rhythm if the patient is unconscious and without a pulse. Arrhythmia recognition. Ventricular fibrillation. The pattern is bizarre with no rhythm of any sort. You usually have no palpable or audible pulse. Rhythm, irregular. Rate, 300 plus, disorganized. QR restoration, not recognizable. P wave, not seen. This patient needs to be defibrillated. Quickly.